Hi, it's Dr. Centeno, and it's almost 1:05 here in Colorado, so we'll get started 3 o'clock Eastern time. Starting a couple minutes late because I guess there were some cyber attacks this morning on a number of big sites, and we didn't know if that also involved the GoToMeeting site. But looks like we have a reasonable number of people signing on, so it looks like everything is going fine. Uh, so Today I'd like to talk about everything you need to know about orthopedic stem cell terminology, but we're afraid to ask. So we'll get into that in just a minute or so, and I'm sure people will continue to sign on as we go. So the first thing is, just wanted to introduce you to the sponsor of today's talk, Interventional Orthopedics Foundation. It's a 501c3 nonprofit dedicated to what you do, interventional orthopedics, dedicated to education, research, and advocacy. And we're really looking to create a new medical specialty that bridges the gap between conservative care and very invasive surgeries. Really analogous to interventional cardiology. And it's a big goal, but to do that, obviously there's a lot of work. So we need your help to build and shape this nonprofit. So if you want to get involved, let us know, and you can actually be very involved in how this nonprofit will change healthcare over the next 20 years. So see interventionalorthopedics.org, which is the website, and there's lots of information there. Also, you might consider joining Interventional Orthopedics Foundation. You get discounts on some of the educational seminars. You can view live webcasts of various events. And you get a chance to serve on IOF committees. You can be part of the Wounded Warrior program, and that's where IOF will pay you to treat with platelet-rich plasma or stem cells wounded service-connected veterans who otherwise wouldn't have the chance to get access to that expensive cash technology. And you get to participate in the patient registry. Right now, we're tracking 9,000 stem cell treated patients going back more than a decade, actually 11 years. And this is the first time that registry has been open for use by other physicians. So it's a very important document, a very important evolving database. And one last thing about IOF, we have the 2017 IOF conference coming up, and it's going to be a big deal. It's our annual ski conference. So basically, not only will we do lots of cool things, we'll have a day of lectures focused on interventional orthopedics and stem cells and PRP. We'll have another half day devoted to how do we deal with the regulatory stuff as a community? What are the best strategies, the best practices for trying to make sure we can all continue to do this work going forward? There'll be a hands-on bone marrow aspiration and liposuction course, and then we're going to hit the slopes in Colorado. It's tax deductible since this is a nonprofit, and we'll send you an invite for all of this after the talk. And one of the unique things about the IOF programs is that these are programs that are focused on gaining advanced skills. So that means you've got level 1, level 2, where you learn a lot more than just how to put things into a joint under ultrasound guidance, where you get into specific structures, how to hit a hip labrum, how to hit a shoulder labrum, how to get into certain ligaments, tendons, etc. And then level 3 courses where we're starting to talk about how to get into advanced structures in bone. So very exciting stuff. Again, I really, these are unique courses. You can't do this anyplace else in any other course right now on the face of the earth with regard to some of these things that are being taught at IOF. So why give this talk? Let's get started. Actually, the reason why I wanted to give this talk was because on LinkedIn, I found myself going back and forth with one surgeon in particular, and it was very, very clear that this guy didn't even know what he didn't know, and that's a very dangerous place to be. Obviously, if we know what we don't know, we know what our limitations are. But I found that he was reading papers and not even understanding what was on the page because he didn't have the background and the terminology to understand what it was he was reading. And that wasn't just specific to this particular doctor. I've seen it throughout this area, meaning that even some of the guys teaching the courses, these weekend courses being put on, don't really fully understand what it is they're talking about because they've never had to read the research and from that research build their own opinions about what's correct and what's not. It's basically been spoon-fed to them by others who may not have actually known what they were talking about. So one of the reasons for giving this talk is to trying to ground everybody in what's out there, what these terms mean, so that we can all start to get on the same page. So obviously there's lots of terminology that's really not covered in medical training. This is just some of what we'll go over today, and it's confusing. Lots of information, hard to understand. Some of these things are thrown out by experts or scientists during lectures, and I think sometimes it just goes over the head of the average doctor sitting in the audience. So I don't want that to happen. If you pay attention to what I'm going to talk about today and you understand it, you'll be more educated in this field than 99.99% of U.S. physicians. So this is how we're going to organize all this terminology today. We're going to look at these basic categories, and then we're going to drill down into those categories. So you'll see this slide, what's up next. It will help you decide where we are in all this. We'll start with basic stem cell terminology and cell biology. So let's get started. These are the terms we'll talk about in that category. Some of these you may recognize, some of these you may not recognize, some of these you may recognize and kind of know what they mean, but you're not 100% sure. So stem cell, we'll start really, really simple. Obviously, that's an undifferentiated cells. It gives rise to more of itself, and it can differentiate into different cell types. But it can also organize a repair response, a very important part of stem cell behavior that we'll discuss today. Pluripotent versus totipotent. Pluripotent is, you've probably all heard of mesenchymal stem cells. Mesenchymal stem cells tend to like to become mesenchymal tissues. So they're pluripotent. They can differentiate into a couple different things. And then there's totipotent, a cell that can differentiate into all different germ layers, plus embryonic tissue. Now, for our purposes, does it really make a difference whether it's pluripotent or totipotent? Not really, just as long as it can actually differentiate in the direction we want. So this is more of a research discussion sometimes than it is a practical clinical one. Paracrine, you've probably heard this term. And if you think of what paracrine really is, it's a stem cell that's acting as a general contractor, barking out chemical commands via signaling to get certain things done. So these are paracrine effects. So the stem cell might bark out a chemical command using VEGF, saying, bring in new blood supply. And the cells out there in the periphery that do that will respond. Or it might say, I need some macrophages to clean this mess up. So it's really acting as a general contractor recruiting subcontractors. Exosomes. These are tiny packets containing many different things that can influence other cells that get excreted by stem cells and other cells too. So these are tiny packets that are thrown out there. Now, one of the more interesting things that exosomes can do is that exosomes can also have instructions to build other proteins. So not only can they contain a protein, but they can also have instructions to build proteins. And that's where it gets really weird. So basically, when exosomes get to the target cell, they can unload their little protein factory, their mRNA, and they can force that cell to produce proteins that the original stem cell needs. So very, very interesting. Basically, the stem cells have the ability to hijack another cell and get that cell to produce proteins. Cytokines, hormones, growth factors. These are kind of all in the same family, but we'll differentiate these. So cytokines are cell signaling molecules that have an effect in other cells and are secreted by all cells. Whereas cytokines describe the whole category of these signaling molecules. Growth factors are just one part of that category. So cytokine examples would be TNF-alpha or interferon. Hormones are similar to cytokines in that they perform cell signaling functions, but they're produced by specific organs like the pancreas. Growth factors, again, are within that umbrella of cytokines, but they tend to produce anabolic or growth effects. So examples might be TGF-beta, VEGF, or FGF. Senescence and contact inhibition. So like many cells in your body, stem cells have the ability to multiply. However, that's not always a good thing, meaning an embryonic stem cell can make unlimited copies of itself, and it's one of the things that we get concerned about in their use, right? They can cause teratomas or small little tumors based on the fact that they may grow too much. So cells that grow are good, cells that grow too much are bad. And when cells stop growing, it's called cellular senescence. So at some point, a signal comes in that says stop. And that's one of the advantages of adult stem cells, is they have the ability to senesce at some point and stop growing. And one of the real advantages of mesenchymal stem cells is that they exhibit what's called contact inhibition. So what that means is that they can grow until it gets too crowded in the local space, and then once they start touching each other, meaning they come in contact with each other, they then stop growing. So it's a very critical thing about mesenchymal stem cells that makes them far safer to use than fetal or embryonic cells, because they have an automatic built-in switch to stop growing. Now, cells can also, mesenchymal stem cells or stem cells in general, can also differentiate. So they can actually replace a damaged or worn out cell and also make a copy of themselves. So they have the ability to be held in reserve for future use. And if we look at different adult stem cell types, we've got two really big ones that you hear a lot about. One is mesenchymal stem cells. These live in many tissues, including the bone marrow and fat, but they're really in almost every tissue, and almost every tissue in your body has some sort of progenitor cell in it. They can differentiate into all orthopedic tissues, so that's nice for us. And they can act as that paracrine general contractor. And they can do lots of really cool things as well. They can transfer their good mitochondria into cells that have damaged mitochondria and that are dying due to lack of energy supply. They can excrete the exosomes, as we've talked about. They can hijack other cells to get them to produce proteins, as we've discussed. Then there's hematopoietic stem cells. These live mostly in the bone marrow, but in lesser quantities in other tissues. For instance, fat has some hematopoietic stem cells, but far fewer. And usually their job is just to create nucleated blood cells. However, they're also naturally recruited in the body from the bone marrow to muscles when local muscle satellite stem cells are depleted. So they've got the ability to repair muscle directly, which obviously for orthopedic use makes them very, very valuable. So you've probably heard about macrophages. I think you probably have some idea that these are cells that help to kind of clean up cellular debris. But you may not have heard that there's something called an activated macrophage. So that basically means that inflammatory cytokines, let's say in a joint, can activate a macrophage and turn it into a Pac-Man-like cell that really starts to rip up the joint. And one stem cell function seems to be that stem cells can deactivate these activated macrophages who would otherwise be breaking down cartilage. So that's a good thing. It can take them from being catabolic to switching off that catabolism. Extracellular matrix or scaffold. This is basically the stuff between cells. Extracellular matrix is the stuff between cells that's natural in your body, and a scaffold is something we add to cells to try to give them substance or signals or clues about what to be when they grow up. And one of the interesting things about ECM or extracellular matrix is that it's believed that young ECM can help cells grow. Old ECM may go the opposite direction. So one of the reasons why we age may be that our ECM gets old. And there's lots of ECM products out there. There's acellular porcine bladder. You can get acellular fat, acellular fetal tissues such as amniotic fluid and membrane. And there are many, many different artificial scaffolds that have been studied. So you can get natural scaffolds that have been decellularized, or you can get artificial scaffolds that are made kind of at the bedside. The problem with artificial scaffolds is while there's a lot of research, regulatory constraints may make it very, very hard to use these new scaffolds coming down the pike. So what's up next? Cell counting. How do we quantify the number of cells that we have? So here are some cell counting terms. And the ones we're going to go over right now: CFU, CD markers, flow cytometry, and the rest. So what's a CFU? This is probably a term you've heard bandied around or thrown around. And it's what's called a colony forming unit. And what you do is, let's say you have bone marrow and you want to get a rough metric of the number of stem cells in that bone marrow. You would throw it in culture in a monolayer culture flask. The cells would adhere to the surface, as you can see off to the right there. And after they attach and start to grow, you can actually stain those cells and look at the number of colonies. So that gives you some idea of a rough metric of the number of stem cells that might be in the sample. Now, it's not an exact count, but it's very good for comparing the MSC content of samples in a research study, for instance. However, it's really not appropriate for clinical use because at the end of the day, it takes a couple days to get CFUs. So if you're at the bedside trying to figure out should I give more or less of bone marrow concentrate, for instance, that's not going to happen with CFUs. Then there's CD markers. This stands for cluster of differentiation. So these are the markers or the surface markers on cells that can help you identify a type of cell. So for example, CD34 is a hematopoietic stem cell. So there's a marker that would be able to tell you that this is a hematopoietic stem cell. So these are markers on the surface of cells. Now, since cells have markers on their surfaces, it follows that a machine would be developed to look at those markers. And that's what flow cytometry is. It's a machine that lines up cells one by one using microfluidics, and literally the cells are lined up one by one. And then lasers are used to read fluorescent antibodies that have been bound to those markers. So the good news is it's fast and it can identify cells. The bad news is it's expensive, and some cells don't really have a single marker to identify them, one being mesenchymal stem cells. Usually have to rely on multiple markers. And it's highly technical. You're not going to get your MA to run this machine. It really takes a PhD to understand how to gate and how to look at these cell populations. So it's one of the reasons why even some of the big companies that manufacture some of the machines that you probably use don't have a flow cytometer, because it takes specialized knowledge to run this type of machinery. They probably rely on a simpler technology, CFUs. We've got two of these flow cytometers, but again, it's an art and a science as well. TNCC, total nucleated cell count. Now this is a critical number because it gets often confused with what I'm going to talk about next. So this is a total count of all cells that have a nucleus in a sample. And it's basically a quick count of the cellularity, the number of cells you have in a sample. It is not a stem cell count. Stem cell counts are some fraction of this. We use it because our studies show that in knee osteoarthritis, there are dosing minimums that we can get to with TNCC. So it's a very helpful number, but it's not a stem cell count. Now you can actually count the number of stem cells, and this can generally be used after isolation and culture expansion. However, this is unusual to see this other than in a study. So the first thing you've got to determine, if you're looking at product information from a company, let's say, that's trying to convince you that they have live amniotic cells, which I'll show you is probably not accurate later, you would look at the TNCC, or the numbers probably being quoted, the total nucleated cell count. They're not giving you actual stem cell counts. A lot of times Adipose SVF guys also confuse this as well. They believe that when they have 300 million cells in a sample, that those are stem cells. They're not. Some very small percentage of that is stem cells. So realize that you tend to see direct MSC counts in clinical studies or in vitro studies where they're looking at cultured cells, but that's very different than a total nucleated cell count. And again, a critical concept, make sure you know which one you're looking at, because I see this get mistaken all the time, and it ends up being transmitted to patients who actually believe they got 30 million fat stem cells in their knee when they got 30 million nucleated cells and well under 1 million stem cells in their knee. So we can count cells. We can also determine in a very simple, kind of quick and dirty way whether or not those cells are alive. So viability means how many cells are alive. It doesn't tell you how many cells are healthy, however. And this is something you've really got to be careful of with viability, because at the end of the day, it only tells you a binary thing. Is the cell living or dead? It doesn't tell you if the cell is healthy. So just like a patient can be living and dead, but there's a lot of territory in between those two extremes. The patient can be very healthy, not so healthy, sitting in an ICU bed, but still alive. So that's all this tells you. And it's usually expressed as a percentage, i.e. 93% viability, or viability is 93%. And the most common way to do this is a simple stain called trypan blue. Live cells pump it out, dead cells take it up. So if you look at the image on the right there, you'll see the cells that are staining dark are dead. The cells that are not stained are alive. So you can count those. Now, one of the things we've seen is that trypan blue doesn't seem to be reliable in counting amniotic and placental tissues. There seems to be a lot of those that don't take it up, but they're actually dead when you use more sophisticated technology to look at this. Realizing that trypan blue is generally the viability number that you see, but it's not the most sophisticated way to determine whether something's living or dead. It's a quick and dirty metric. So we'll now talk a little bit about PRP and some general PRP terms. And some of this may be a review for many of you. We'll look at these terms in particular. So, as we all know, PRP is concentrating platelets in plasma. It can include or exclude white or red blood cells. And I'm giving you some of the Malanga classification here because I think it's being used more commonly than the Mishra classification. So this is LR-PRP. You tend to see that a lot. It just means leukocyte rich. It's generally the red stuff off on the left there in the picture, and not the amber stuff. And it's got increased WBCs and RBCs, and that may have negative impacts on tissue depending on what you read. Then there's leukocyte poor PRP, and it's generally the amber stuff that you see on the right there. Then you can concentrate PRP, and usually this is expressed as a number over baseline. So most bedside units would get to 3 to 7x over baseline, so 3 to 7 times over baseline platelet concentration. A few can get higher with a double spin, and obviously you can use lab-based methods to get even much higher. So we'll routinely use 10x, 14x, 20x PRP depending on what we're trying to accomplish. Now, platelets can be activated. So one of the things to understand is that platelet activation does two things. One is it helps those platelets form a clot, by depositing fibrin through fibrinogen, but it also helps to push out growth factors. Now, you can artificially activate a PRP sample through thrombin or calcium chloride, and you can also have platelets that are just exposed to collagen or exposed collagen, and that activates fibrinogen to begin making fibrin. So in many instances, there really is no need to activate PRP because it's activating in many of the damaged tissues that we inject into automatically. So let's talk a little bit about adipose cell terms. So we're going to talk about adipose graft, mechanical emulsification, microfractured fat, and SVF. So an adipose graft is simply taking the product of a liposuction, putting that into a tube and doing a low grade centrifugation of that, and you end up with oil on the top, as you can see in the picture there to the right. You end up with fat in the middle, and you end up with blood on the bottom. Now, realize that this is not a stem cell procedure. The cells are trapped in collagen. So it's a fat graft, and it's one of the reasons why fat grafts have less persistence in cosmetics than stromal vascular fraction, which we'll talk about, where the stem cells are freely available. Then you can mechanically emulsify that fat. So you can pass it back and forth through lots of different types of grates, which will chop it up fairly finely, and it'll actually look like a liquid, and it can be injected like a viscous liquid. The problem again is that it's not a stem cell procedure. From a microscopic standpoint, you have chunks of fat with cells that are trapped in collagen. So when we've tried to get any viable cells out of this, even though it looks liquid, there are none. So again, this is just a fat graft. Then there's microfractured fat, where you can actually use small beads to be able to break up the fat further. There's some theory that these cells might escape these little, or mesenchymal stem cells might escape these little tiny bits of fat, but there's really no published data that I've seen to that effect. And again, still really not a stem cell procedure. Then you've got SVF for stromal vascular fraction. We're using an enzyme to break down the collagen bonds, releasing the cells, and then you can get a stem cell fraction. A small percentage of those cells are stem cells. So again, don't make the mistake. I see a lot of guys using FAT-MAID. When they get 30 million cells, they're telling the patient you got injected with 30 million stem cells. Not true at all. You're talking about a small percentage of those cells, 1 to 5%, depending on the age of the patient, that are actually stem cells. But this is a stem cell procedure. You've got freely available cells here. You can culture this all day long and get cells out of it. However, it's currently illegal in the US. So regrettably, our FDA has determined that this is over the minimal manipulation line, and I'll talk to you about that in a little bit. So let's talk about a few bone marrow terms now. BMA, BMC, BMAC, HDBMC. So BMA, bone marrow aspirate. This is where a trocar is used. You place it through the bone. You pull out the liquid fraction of the bone marrow, so that's why it's called an aspirate. It's not a biopsy. It's hundreds of times safer than liposuction. Generally complication rates of 0.005% versus liposuction complication rates, even mini liposuction, of 3 to 5%. And the best practice to use here is to draw small volumes from multiple sites at the PSIS. Again, a big mistake I see people make, a novice mistake, is they've been taught by some guy at a weekend course to stick it in there, draw it out, stick it a little further, draw it out. If you're doing that, you're dramatically reducing the number of cells available to you, and you're really shortchanging the patient for your convenience. So multiple bone sites, 3 to 5 per side, for a total of 6 to 10 different bone sites would be the way to do this. So BMC, BMAC, this is bone marrow concentrate. You're just taking the stem cell fraction of the bone marrow aspirate, which is in the buffy coat in the middle, and this is also called a same-day stem cell procedure. So what's in there? You've got mesenchymal stem cells, hematopoietic stem cells. You've actually got quite a few platelets. So it's interesting that we add platelets. OCR cells, mu cells, macrophages, pericytes, and EPCs are the ones that we would be interested in from a regenerative medicine standpoint. Then you've got high-dose BMC, and you really need a lab to do this because you're dramatically increasing the efficiency of concentration in order to get much, much higher stem cell numbers than you could out of a bedside machine. So let's talk a little bit about fetal stem cell terms. So amnion chorion, amniotic stem cells, ASC counts, terminally sterilized, and cord blood. So we all know placental tissues, right? The placental tissue describes all of these. And you've got amnion and chorion, which are different parts of the birth sac. And these are generally sold as acellular tissues. But be really, really careful. They are frequently, fraudulently misrepresented as stem cell products. And we've tested many of these. We've never seen any living cells that were viable in any of these products. However, you talk to the reps and they'll tell you all day long there's stem cells in there. And you'll see doctors fraudulently advertising this stuff online, that they're using a stem cell procedure. These do contain extracellular matrix, they contain growth factors, so they may have an effect through that, but they're not having an effect through live stem cells. Then there's amniotic stem cells. Now, again, realize that amniotic stem cells aren't found in the products that you're buying from these folks, even though the rep may tell you otherwise. And realize that this term is used to describe a heterogeneous cell population, meaning multiple different types of cells that are pluripotent and have high growth rates, but are present in low numbers in live amniotic tissues, not the stuff you're buying from these reps. So here's an example of a word of caution. So you see this is actually from this company called Surforce. You can see here that they're comparing at the top line their total cell concentration, 900,000 for BioD Restore, a competitor. AmnioFix has 3.7 million cells, and Surforce has 4.3 million cells. Now I'm going to use a couple concepts you just learned to be able to show you why this is really BS. So one of the problems here is that most physicians would look at this and believe that under the next line, viable cell concentration, they were buying a product like Surforce that has 2.7 million stem cells. Now, that's not true, because even under the perfect conditions, if this stuff was taken live from the OB ward, the amniotic stem cell content would only be 1.5% of that total cell number. But more importantly, there's another way you can tell that this is complete fiction that's being shown to you here. And I'm going to show you why. So AmnioFix, this middle one, is a dead product. It's a powder, so it's been dehydrated. It's terminally irradiated with gamma radiation to kill everything else. So this company has somehow measured that there are 1.3 million live cells per ml in AmnioFix. Now that's impossible because AmnioFix is dead tissue by definition. And they're claiming that the viability is 36%. So you've got some sort of Frankenstein cells here that are reconstituting like dead salamanders. Again, so it shows you that this data you're being shown here is fiction, primarily because AmnioFix is dead. And why did this happen? I can tell you why it happened. We actually attempted to do a live dead stain on AmnioFix, dead tissue, and the problem was it doesn't take up trypan blue like other cells do. So you have these little fragments that would read in a simple live dead stain that they're alive, but nothing grows out of this. And when you use more sophisticated flow cytometry, there's nothing living. So long story short is you've now learned how to read through some of the smoke and mirrors to understand a little bit more than, again, 99% of the positions that are out there. So terminally sterilized is what it sounds like. It means that some company is going through a lot of rigmarole, including gamma radiation, to try to make sure that they're killing all living cells. Many of these amniotic cell products are also terminally sterilized, which obviously means they are by definition dead. Cord blood. This is the blood obtained from the umbilical cord. It contains multiple stem cell types, and it contains mesenchymal stem cells in the Wharton's jelly part, which is all down here, and hematopoietic stem cells in the blood itself. Now realize it's illegal to use this in the US without FDA approval for that specific indication. It's only approved right now for cancer use. So the bottom line is, if a rep approaches you, and we've had a few recently come to our clinic saying that they can get you cord blood, be very, very cautious. They're selling you an illegal drug product, and you're as responsible for the use of that illegal drug product as they are selling it. So be very, very careful with this. So what's up next? Let's talk about cell culture. Because no physicians that do this kind of work actually have ever been involved in cell culture, this is where a lot of doctors, when they read papers, it just goes over their head. They don't know what's being discussed. So let's talk about it so you can know. So these are the terms we're going to go over here. So expansion or expanded. So all this means is the cells have been grown to bigger numbers, a very easy concept. Their numbers have been expanded, or the volume of the cells has been expanded. Confluence or confluent, very important metric. When cells grow in monolayer culture, and monolayer culture simply means that you're putting them in a flat flask where they grow on the bottom, and I'll show you that in a second. When the cells are touching, it's called confluent. And that's generally written as a percentage of the total area that the cells are occupying. So you might say it's 85% confluent. Now, this is a critical concept in growing cells, because if cells become too confluent and start to touch each other, mesenchymal stem cells, for instance, in culture will automatically get a signal to stop growing. So if you're trying to grow them further, they're not going to grow. So one of the things you do in cell culture is you get them to a certain confluency, let's say 70%, so they're not touching, and then you take them and put them in other flasks at a lower density and have them grow again to 70%. If they reach 90% at any time during that, you're kind of screwed, because your cells aren't going to grow anymore at all. So monolayer culture is what we're talking about. So we have this flask off to the right here, and the cells are growing on the bottom of this flask. What's on top here, so the top layer here, is merely the food for the cells. The cells are attaching to the bottom, and that's how they're growing. And this is really the most common MSC expansion method. And you use these little specialized monolayer culture flasks to do it. Now, passage. This is a critical concept if you're reading research papers that, again, goes over the heads of the average physician. Every time cells in culture are fed, usually every 2 to 4 days, it's called a passage. So this is usually expressed with the notation P. So for instance, P2 means passage 2. And the thing you've got to remember is that lower passage cultured stem cells are generally much more potent than later passage cells. I.e., if you had read a paper and they said that the patient was treated with P2 cells, those are going to be highly potent. But if you read a paper and said the patient was treated with P7 cells and it didn't work, you would scratch your head and say they probably grew the cells way, way too long, and you've got cells that are really not functional. So just recognize that that's a critical component of reading research in this area about cultured cells. How long did they grow the cells? Were they early passage cells or late passage cells? FBS and FCS, fetal bovine or fetal calf serum. And this is really what it sounds like. It's kind of gross, actually. Baby calf blood. It's loaded with nutrients and growth factors, but there's obviously concerns about prion disease vectors, mad cow disease, Jakob-Creutzfeldt disease. Despite that, this is really still the world's most common culture media to grow cells. Now, when we started growing cells back in 2005, we actually have always used platelet lysate. And that's just created from lysine PRP, so it's growth factors in serum without platelets, because all the platelets are lysed. and it's very rich in growth factors, and they obviously don't have the prion concerns. And it can be used autologous, or it can be pooled from many donors. If it's pooled, it's called pooled PL. And it's increasingly common culture media in cell expansion. When we started using it back in 2005, there really weren't but a handful of people in the world using it. Nowadays, I'd say there are a good 20–30% of clinical cell culture groups who use pooled PL. So interventional orthopedics and orthobiologics, we'll do this, then regulatory, then I'll take some questions using the chat box off to the right there. So interventional orthopedics and orthobiologics. I'm just going to go over a few terms here because this is kind of the focus of this talk. And these are the ones I see a lot of physicians kind of misunderstand. So interventional orthopedics, the precise guided injection of biologics to enhance repair, or the use of percutaneous devices to approximate or alter orthopedic tissues. Now, what is that? Well, what interventional orthopedics really isn't is this off to the left. A simple shoulder joint injection, a simple knee joint injection, a simple hip joint injection. That's about 95% of US physicians who can use guidance to get into a joint. That's pretty much all they know how to do. The problem is that there's so much more that can be done. And if this field is ever going to reach its zenith, we've got to educate an army of physicians out there to know how to compete head-to-head with orthopedic surgery by getting these cells and other increasingly advanced biologics into every nook and cranny of that joint possible. So for instance, about 1% of US physicians are actually doing this, which is hitting all these structures inside a hip, or hitting all these structures inside a knee, or hitting all these structures inside a shoulder. That's when we compete head-to-head, and actually in many instances out-compete orthopedic surgeons and can offer patients a better mousetrap. Not when you just sort of learn how to put some stuff into a joint under ultrasound. And if you want to learn how to do that, the place to do it is IOF. It's the only place on earth right now where you can learn in a structured environment to do this, where you can put cells in all of those different areas, not just throwing them into a joint and calling it good. So if we're ever going to, again, outcompete orthopedic surgery, which we have the ability to do all day long and twice on Sunday using these new technologies, it's through this type of education. So fenestration, from the Latin, fenestrem, window. It's like aerating your lawn in the spring. You go ahead and you poke multiple small holes in a tissue to try to provide channels for healthy tissue to infiltrate. BML, BME, bone marrow lesion or bone marrow edema. This is a fluid-filled area within the bone. Looks like this on a T2 image off on the right here. And really what it means is there's microfractures in those trabecula. And of all the different things, from meniscus tears to lost cartilage, this actually has the highest correlation with knee and hip pain. So what's interesting is that while we're very, very focused on meniscus tears and lost cartilage, they have relatively low correlations with pain, whereas BMEs or BMLs have a high correlation with pain. And consequently, this is a target for orthobiologic treatment. We treat it all the time. It's part of those IOF courses in level 3. So we'll finish out with regulatory, and then I'll be happy to take some questions on any terms I didn't get to, any concepts I've gone over, etc. So regulatory terms, HCTP, what is that? Human cells, tissues, and cellular and tissue-based products. It's an FDA term. Basically, it means all the kinds of things we might use. 1271 is 21 CFR 1271, which is basically the regulations regarding these HCTPs. And the single biggest part of that regulation that you should be concerned about is 1271.15b. That's the same surgical procedure exemption. So basically, if the tissue being used is autologous and minimally manipulated and used homologous, and it's used in the same surgical procedure, then it moves from the drug category into the practice of medicine category. Now, one of the problems is that there was a recent FDA hearing. You can see a picture of the lovely Julie Cerrone there off on the right, lecturing at that, or actually not lecturing, but giving her testimony. And that FDA hearing was on further restricting our rights under 1271.15b. And one of the things I really want you to consider doing is coming to the IOF conference in February, because we're going to go over all this and we're going to try to figure out how best to maintain those rights, because right now those rights are under threat. So homologous, non-homologous, the FDA defines it as performs the same basic function or functions in the recipient as the donor. Non-homologous, if you're using a tissue non-homologous, it may be classified as a drug. And again, a lot of people don't understand that. And right now, this is a fairly complex issue because you've got very inconsistent and nonsensical application by the agency. So basically, they're saying, for instance, that if you take abdominal fat and put it into a breast for breast reconstruction, that's non-homologous. Now, that makes no common sense. It makes no medical sense. But they're considering the only homologous use of breast tissue or of a breast would be lactation. So again, we've got to be very, very cautious. It's one of the reasons why I want us all to get together in February to go over the best way to deal with these sorts of things, because just using this one thing right here, FDA tomorrow could make all procedures, all same-day stem cell procedures in the U.S. go away. So very, very important thing to consider. Come on out to Colorado so we can talk about all this. More than minimally manipulated. This is where the FDA draws a line in the sand. It says everything to the left is a tissue, everything to the right is a drug. So if the processing is more than simple centrifuging, mixing, chopping, adding water, crystalloids, it's more than minimally manipulated. If it's on the other side of that, it's less. And it's one of the reasons why stromal vascular fraction for fat is considered a drug. Now, do I agree with FDA's position on that? No, but it is what it is. 361 versus 351, critical concept. 361 means that it's a much less regulated tissue. There are no clinical trials. It's a simple registration. That's one of the reasons why we're seeing a massive proliferation of amniotic tissues right now. And it's one of the reasons why we're seeing lots of fraud where these companies are claiming that these are stem cell products, because all they have to do is to go and literally go online and register the tissue. Now, the FDA may show up and inspect their 361 tissue processing site, but that's very different than a biologic drug that has to go through 3 full-phase drug approval trials. That's a 351. So again, 361, relatively easy deal, less expensive. 351, incredibly, ridiculously expensive and time-consuming. And BLA IND, that's a biologics license application, investigational new drug. So basically, a BLA is the tissue version of an IND. That's the way to think about it. So I'm going to say a little bit about IOF, and then I will take questions. Again, consider joining IOF today. We will send you an email to join. And consider coming out for the IOF conference. Not only is it going to be a great group of physicians teaching you about these complex regenerative medicine things, there'll be a course there as well. You can hit the slopes, and we can spend a half day talking about all the different things we need to do to protect ourselves. So let me take some questions now. Just need to pull this out here. And if anyone has questions, what you want to do is to use there's a question box off to the right, and that's where you type your question. So I'll just try to read them here. So first question, in adults, how likely bone marrow lesion may get resolved over time? When would be appropriate time for general treatment of BML? Yeah, Alireza, good question. So a bone marrow lesion can resolve on its own. Sometimes it just takes, if it's an acute issue, it just takes resting the part. Really what we're talking about here are chronic lesions that won't go away with rest. And in that case, we do treat them. We will take a small little micro trocar and work it into the bone under X-ray guidance into the lesion and inject. And the good news is, using that methodology, on follow-up MRIs, they generally go away, and it seems to help. Now, we're in the process of pulling together some of that data in, for instance, knee arthritis patients that have had bone marrow lesions treated versus those who have not, to see if there's a clear advantage. Sammy, what is activation of stem cells? Yeah, so just like PRP, stem cells can be activated as well. So all activation means is the same thing. You would add in calcium chloride or thrombin to try to produce for instance, a bone marrow clot or a bone marrow concentrate clot. That does activate the platelets in there. It activates the fibrinogen to produce fibrin. Is it absolutely necessary in most circumstances? Probably not, but it's commonly done. Let's see. Kevin, can you talk about the difference between ACS in terms of... yeah, Kevin, rephrase the question. I'm not 100% sure what you mean in the broader context of stem cells there. Orlando, is the difference in the efficacy of cells grown in FBS versus PL? Yeah, Orlando, very good question. There's a bunch of research on that shows that cells grown in PL work just as well as those grown in FBS, and there's some indication that they may work better. As an example, one of the interesting things is that the cell numbers, when you switch to PL, tend to go up, and the growth rates tend to go up. Why? It makes sense. You're using something that's a xeno product, meaning not a human product, and the cells at some level know that, versus using a human product. So yes, there seems to be an advantage to using PL based on what we've seen. Let's see. Rick, based on SVF restrictions by FDA, there's currently really no way to use Adipose to create a viable stem cell procedure. Yeah, Rick, at least right now, that's what it seems to be. Again, using a fat graft isn't really a stem cell procedure. You know, if you're using it for cosmetic purposes, there are different ways to use different fractions of that fat, or maybe microfractured fat, to improve your results. But as far as doing an actual stem cell procedure with viable stem cells, that's probably true. Oh, okay, autologous conditioned plasma. Yeah, so I think what Kevin is talking about is there are multiple different types of what's called autologous conditioned plasma. And one of those is, for instance, has got the moniker orthokine or regenokine. So you can basically incubate blood and serum, so the white blood cells, certain white blood cells will produce IRAP, interleukin receptor antagonist protein, and that's a natural anti-inflammatory. Now the problem is that if you look at the research on IRAP, it's okay. It's probably not as good as the average PRP shot for mild osteoarthritis. And if you talk to vets, they'll tell you the same thing. U.S. veterinarians have been using it for many years here in the U.S., and they will certainly say it works better than a steroid shot, but probably not as good as a PRP shot. Let's see here, so if I can get to these here. Ida, can you explain uses for LRPRP versus LPPRP? Yeah, so Ida, I mean, right now, it's a good question. Meaning, what Ida is asking about is leukocyte-rich versus leukocyte-poor PRP. And the bottom line is that at the end of the day, no one really knows. There are some in vitro studies that seem to go against using, for instance, leukocyte-rich PRP in tendinopathies. There are some in vivo studies that seem to show promising results for leukocyte-rich PRP. I can tell you as a clinician, one of the problems with using leukocyte-rich PRP is the flare-ups can be epic. And so when we switched to leukocyte-poor PRP, we had much less in the way of severe flare-ups. So there may be a little difference, there may be a lot of difference that we ultimately find out, but from a practical standpoint of just being a clinician and doing 300 or 400 platelet-based procedures a month in this clinic, it's very, very nice not to have those epic flare-ups. Um, Sean, what do you think of MSC adipose cells used in spine surgery is the ability to differentiate into bone? Yeah, Sean, I don't know why you would want to use adipose cells to differentiate into bone. Just recognize that one of the things I didn't cover is a simple concept in cell therapy that's been uh, demonstrated by a number of different studies, and that is the closer you are to the target tissue, the more likely it is that that target tissue is going, or that cell is going to produce the target tissue. So as an example, you can take bone marrow stem cells and use them for cardiac problems that were taken from the pelvis, and they'll have a certain efficacy. And then you can use cardiac stem cells that were taken from the cardiac muscle, and they'll have better efficacy. In the case of growing bone marrow stem cells do that all day, twice on Sunday, naturally. So there's really no rationale to use adipose stem cells to try to grow bone. Can you get them to grow bone? Yeah, if you hit them over the head with a hammer, but why would you want to? I mean, there's just no rationale to do it. You have the patient there in spine surgery, you can quickly take some bone marrow aspirate, you can quickly throw it into a bedside centrifuge to spin it down. You're not going to get the best product, but you'll get some reasonable product. And you can put that and use that in spine surgery without having to deal with anything adipose. And you're going to get a cell that's going to be much more likely to become bone. Now, if you're trying to use facial aesthetic work, it would be silly to use bone marrow for that. Mimi, are there doctors in major cities doing what you do? It's going to be the way future being treated. Yeah, Mimi, again, lots of different doctors do this kind of work. My focus here is representing IOF. So lots of different doctors do this kind of work. You may want to contact IOF and get a list of who their members are to try to see some of the doctors that have taken these advanced courses. Let's see, ZBIG, what is PRP lysate? Platelet lysate is basically getting rid of the platelet bodies to break out all of the growth factors that live inside platelets. So you could consider PRP like a timed release, meaning that over time those growth factors will be degranulated from the platelet, whereas a platelet lysate is like an immediate release where you've got all of those growth factors immediately available for the patient. So that's the difference. Dan, is the pool PL you use virally inactivated? Yeah, Dan, we don't use any pool PL. The only PL we've ever used is autologous. So we don't use any pool PL here. My statement before was there are many cell culture labs that are using pool PL, but we only use autologous PL. So again, no reason or need for that. Jim, are you familiar with Sky Biologics PX50? We have a facility close by who uses it, and they were stating it's a better treatment than stem cell. They also do it for approximately half the price. Any suggestions? Yeah, Jim, it's not a stem cell product, so if someone's telling you that's consumer fraud. We've tested PX50. It has absolutely no stem cells in it. It's a growth factor product, so it's like an expensive version of PRP. So if you want to compare it to a PRP injection, it's actually double the price of a PRP injection, if not triple the price, and you're getting the same thing. For stem cells, it's not a stem cell procedure, so it can't be compared to a stem cell procedure. So at the end of the day, again, even though the doctor will tell you this is a stem cell injection, the doctor has no way to verify that. He was told that by a rep who wanted to sell the product, kind of like a used car salesman trying to sell a car. But at the end of the day, when we test it, we take the car out for a drive, there are no cells in it. It's like a PRP shot, and if you're comparing price, it should be compared in price to a PRP shot. Ida, so is the removal of and presence of WBCs and PRP more critical than platelet count? Yeah, I don't think anyone knows that at this point. Again, I can tell you that from a provider perspective, it's nice to see that you don't get the huge flare-up. I personally think it tends to work better, but I don't think anyone's ever compared these in a big way head-to-head for multiple indications. Um, Nick, since flow cytometry is not always practical or available, do you suggest a particular method of MSC analysis so we can compare apples to apples across BMA studies? Yeah, Nick, I think that total nucleated cell count is the way to go. We count every single thing we've ever put into any patient, whether it be actual MSC counts and culture expanded stuff, or total nucleated cell counts in same day. TNCC works great. Based on what we've seen, it gives you a rough metric, and it can be used at the bedside to adjust dose. So I think right now, of all the different methods we have, the three methods, TNCC, CFU, and flow cytometry, TNCC is the most reliable and quickest and dirty method to probably get to a, quote, dose. Now, something else may become available, but right now, it seems to be the best way to go. Ida, is there evidence that there are enough cells in the aspirate for BMAC to be efficacious in a clinical setting? Yeah, Ida, we've been using BMC for a very, very long time. We've published the world's largest papers on that topic, as has Felipe Hernicau, who has published more in the world of bone healing. So yeah, I don't think there's any issues with the number of cells in BMC. You got to recognize that that if you look at the efficacy of these things, it's related to probably a certain number of cells, and you can go below that number, like we showed in our knee osteoarthritis dosing study. But once you're above that number, you're probably fine. Alireza, yeah, so Alireza, we will be sending out a link to everyone where there'll be a recorded version of this, so you will be able to watch it again. I know I went really quick through many of those things. Sammy, blood-derived stem cells, is there any evidence for them? Yes, Sammy, there really are not very many blood-derived stem cells, meaning that at the end of the day, if you just take peripheral blood and try to culture viable stem cells out of it, you're not going to really do that well. So there are very, very few circulating stem cells. There are some, but much, much less than you would find in other tissues such as bone marrow or fat. Ida, what do you think about concentrated PRP, solid membrane for orthopedic and wound healing? Ida, I think you're referring to platelet-rich fibrin. So you can form a platelet-rich fibrin clot. Now, so far, the only study I've seen with it in orthopedic applications has been the one by Dr. Scott Rodeo out of Hospital for Special Surgery in rotator cuff repair. The nice thing for the surgeon is it can be sewn into the clot, so it kind of fits with the surgical mindset, but it didn't really show efficacy versus a recent paper with injection that did show efficacy, injection not of obviously a clot, but of liquid PRP. So, so far, I wouldn't say that PRF is probably going to be a biggie. Sean, do you think HCTP products should have stricter regulations? I think Sean has left. I think it just depends on what we're talking about, but it looks like Sean's gone. Adipose, do you recommend regenerative treatment for symptomatic vertebral hemangioma? That's something we generally don't treat. Okay, any other questions coming up here? Let's see, Rolandis, do you have any experience with homing effect from stem cells? I mean about side effects by treatment from joint to the PMC, like improvement, for example, by asthma and diabetes. You know, Rolandis, we generally don't see cells when we place them in a joint affect other parts of the body. That's one of the nice things about precise placement and documenting that we're in the joint, is that we can generally make sure that that's where they're acting. So we really don't see that. Now, you can see that sometimes if you're giving IV stem cells, which we don't do, because on the positive side, IV stem cells are going to get all over the place. They're actually going to go through a pulmonary first pass. About 96% end up in the lungs, and then they'll egress from there. On the downside, doing a safety study with IV stem cells is a nightmare, right? Because if I put them in the knee and the knee doesn't get cancer, I'm pretty sure that these aren't cancer causing. But if I give someone IV stem cells, I better have a huge, meticulously done study that shows that that person's cancer rate in general wasn't any higher than someone who never got IV stem cells. So it's kind of a study research nightmare. Let's see, Sandra, if you have extremely high serum CRP, do not get it down, are you just transferring inflammation? Um, Sandra, not quite sure what you're talking about there, meaning I think what you're saying is that if you have high inflammatory cytokines in your blood, might those get transferred to an area where those are injected? Yeah, they might, and just recognize that at the end of the day, these are autologous products, so the health of the patient does have an effect. Now, the good news is, for instance, for PRP, it doesn't seem to make a big difference, but it can in certain patients. So being healthier in general, however, makes autologous products work better. Mimi, best to have PRP done with the lab rather than a bedside centrifuge. Yeah, Mimi, that's how we do it. Everyone, to each his own. Again, my job here is to represent IOF, and that includes doctors who use labs like we do, doctors who use bedside centrifuges, etc. Let's see, something coming in from Greg there. I just saw the Chris part. Ida, oh wait, no. Is there evidence of LP-PRP in treating rheumatoid arthritis? Ida, I've never seen a LP-PRP study out there in treating rheumatoid arthritis. Let's see, Alariza, would you consider using CoQ10? Yeah, Alariza, I don't know the answer to that. There's certainly some promising early evidence of CoQ10 in all the areas I discussed, but I don't know the answer to that with stem cells yet. Greg, what's your feeling with different new BMA devices like Marrow Solutions? Yeah, Greg, I've looked at that pretty closely, and so far I'm not convinced at all. If you really look at the information put up by Marrow Solutions, there's a white paper where they compare it against a single site low quality draw, so that doesn't tell me much. And then there's another paper where Mike Scarpone has gone in and tried to compare it to the published stuff that's out there that other companies have put in, but it's not a head-to-head comparison, meaning that you don't know whether or not different populations were tested, etc. So the research is kind of a mess right now on Marrow Solutions. In addition to that, we tested the Marrow Miner, which is like Marrow Solutions on steroids, where this thing goes in through a 11-gauge trocar and chews through 10 to 15 centimeters of bone marrow. So this is, again, like Marrow Solutions on steroids. And at the end of the day, it wasn't any better than a 3 to 5 site draw using a $30 trocar. And I suspect that Marrow Solutions won't be either. So again, nice concept, but I don't think it's real based on the information we've seen so far. Now, we have asked Marrow Solutions to give us some of these to test, and we would test them at our expense. It hasn't happened. So if this thing is really for real, then we'd love to test it, and if it is really for real, we'd love to use it. If it's not really for real, we won't be shy at all in telling folks it's not for real. I suspect that's the reason why we've never gotten any. Okay, guys, so it's about 2:12. I think we'll start wrapping this up here. It looks like we've had a bunch of great questions. We will do another one of these in about 3-4 weeks, focusing on bone marrow, focusing on reading knee MRIs for regenerative medicine. Greg Lutz, who was just asking some questions, hopefully will be doing one for IOF on some of his work with platelet-rich plasma and discs. And our goal is, again, to just keep throwing good information out there. We hope you come to these conferences and courses so that we can keep raising the bar in this area. And one of the ways to raise the bar in this area is to educate. So that's what we want to try to do. So thank you so much for watching. Have a wonderful afternoon and a wonderful weekend. And I'm going to probably go upstairs and see some patients. So thank you so much. And thank you, Rolandis, for your kind words, and others that are pinging in there. So have a wonderful day.